screen visible to everybody?
Yes, ma'am.
Yes.
Okay. So today we would be starting off with schizophrenia. We would be discussing about the clinical picture of schizophrenia today. And tomorrow we will be discussing about some case studies. Okay. Mm, okay. So, yeah, I'm a fan of history, so I would always like to start with the historical background. And in the next sessions also, you would be finding me talking about the history of psychology on a lot of occasions. Because the history of psychology is something which is very interesting, and once you get a hand of it, you can actually make sense of how things worked during those particular periods and how things still work during this particular period. And every person who has contributed to the history of psychology, who has contributed to what psychology is today and to what clinical psychology is today, has gone through immense struggle to do that, because we all know the kind of stigma that we have to face as clinicians. So, yeah, the first person who kind of came up with a formal term for schizophrenia was Emil Kraepelin. It was in 1896, and he came up with two names. One was dementia precox, and the other was manic depressive illness. So he differentiated major psychiatric illnesses into two clinical types, because back then there were no classification systems like we have now. Right now, the two classification systems which are mainly used worldwide is one is the one which is laid down by WHO, known as the ICD. ICD-10 version is currently in use. ICD-11 is on its way. It might be released in 2022. Okay. And the other one, which is commonly in practice in India, is the one which has been released by the American Psychiatric Association, which is known as DSM. And the current version which is going around is DSM-5. So back then there were no such classificatory systems, and it was Emil Kraepelin who kind of differentiated between two different kinds. One he named as dementia precox. So dementia, as you know, it is an illness of older patients, of older people. It's an illness which is characterized by marked cognitive impairment, difficulty in executive functioning, like thinking, decision making, remembering, difficulty in memory, in all these particular areas. So these kind of problems, precox is not happening in the older age, happening pretty earlier than the older age. This is what he kind of meant by this, which included paranoia, catatonia, and heaviphrenia. We will be exploring these terms later on. And he also signified about manic depressive illness, because again, during those periods, there was this particular illness as well, which during the manic period or during one particular period kind of seemed similar to schizophrenia. But after a few days, the person would kind of return to normal or might swamp into depression, which in today's world we kind of know as bipolar disorder. But back then it was kind of confusing. Either a person might have schizophrenia like symptoms which persisted for a pretty long period of time and kind of remained persistently there till this person's death, or a person might have episodes of such symptoms occasionally. So there was this confusion. So there was two terms, dementia precox and manic depressive illness. Next came this person in 1911. His name was Eugene Bleuler, and he renamed dementia precox as schizophrenia. So the term that we know today has been termed by Eugene Bleuler. What is schizophrenia? It means mental splitting. Recognize that this disorder does not always have a poor prognosis as described by Kraepelin. So Kraepelin had mainly kind of referred to those kind of illnesses under dementia precox, which did not have a good prognosis. But Eugene Bleuler kind of classified that no, there were certain groups of schizophrenia which did have a good prognosis. And there were certain kinds of schizophrenia which had a poor prognosis. Prognosis is as in poor outcome. And by the way, by mental splitting, it doesn't mean that a person has two personalities. Often people kind of make this common mistake. Somebody with schizophrenia has two different types of personalities and many other things, but no, it's not two personalities. Okay, it's about the person behaving in a totally different particular pattern than his normal pattern. Okay, so he also recognized schizophrenia consisted of a group of disorders rather than being a distinct entity, and he used the term a group of schizophrenias. These were the four A's which were mentioned by Bleuler. So this was Bleuler's fundamental symptoms of schizophrenia, which he also called as the four A's of Bleuler. One was ambivalence, which is like a marked inability to decide for or against. So, a person with severe schizophrenia might express immense love for his mother and at the same time discuss about plots to kill her. Okay, so this is like ambivalence, two extreme forms of emotion at the same time. This was actually an example which was given by Bleuler himself. Autism, withdrawal into self. Now again, I would be covering autism with all of you next week. So autism, as we know right now, it is a disorder which is more which is for children. Autism spectrum disorder, usually diagnosed in children. But the term autism, it actually means somebody who is withdrawn into self, like somebody who is in a glass house. So somebody who is in a glass chamber, the person is unable to express what he wants to, kind of what he is feeling, and at the same time the person is unable to understand what people in the outside world is trying to explain him. So it's a similar kind of a situation for a person who is schizophrenic as well. In autism, it happens for children. Like currently, the ASD is for children. The diagnosis is for children. So this situation happens for children. But somebody who's suffering from schizophrenia, remember the diagnosis is always made in a adult. Generally the diagnosis happens when the person is an adult. However, it might start from the age of 12 as well. But still, remember, somebody, it's an adult who is experiencing something very similar, unable to express his emotions, unable to express his thoughts. And at the same time, he's unable to understand what the other person is also trying to convey convey to him. So affect disturbances is the third A, that is disturbances of affect, like inappropriate affect. We will be discussing inappropriate affect. Association disturbances. This is loosening of associations. This refers to loosening of associations in thought. Okay, and any problem in thought is reflected through speech. That is the only way how we can kind of identify that the person is having difficulty to associate between concepts in thought. Okay, and in 1959, this person, Kurt Snyder, he described symptoms which were not specific of schizophrenia, but were of great help in making a clinical diagnosis of schizophrenia. Like I being an MPhil, we are often always tormented with Snyder's first rank symptoms. We are kind of asked this question in Viva all the time. So basically, back then, Snyder's first rank symptoms were kind of the gold standard for diagnosing somebody with like schizophrenia. Right now we have ICD and DSM, but back then it was Snyder's first rank symptoms. So what are the first rank symptoms? And remember, first rank symptoms should always happen in this particular order, the order in which I'm presenting. Okay, so audible thoughts, voices speaking out, thoughts aloud, or thought echo. So the person could either hear voices who are speaking out his thoughts loudly, or it's the other term for this is thought echo. Like whatever the person is thinking is being said aloud. That is what the person is experiencing. And audible thoughts, as in the person can hear it, that all his thoughts are being kind of shouted aloud. Okay. Voices heard arguing. So it's like two or more hallucinatory voices who are discussing the subject in third person. So two or more voices who are discussing the person, about the person. So they're usually discussing about the person in a bad light. They're usually bickering about the person. They're usually talking bad things about the person in concern who is kind of getting the hallucinations. Voices commenting on one's action. So it is known as live commentary. So it's like whatever the person is doing, the person can hear a commentary on whatever he is doing. Okay, so all these are associated with auditory hallucinations. And remember, auditory hallucinations are most common in schizophrenia than other forms of hallucination. Thought withdrawal. Now, thought withdrawal, now these are disorders of the thought. I would be, again, see, I will be dealing with all the disorders separately, but this is what Snyder's first rank symptoms are. So first he refers to perception. So wherever hallucination is a disorder of perception. Now perception is something which is concerned with our five senses: sight, hearing, taste, smell, touch. So that is what perception comprises of, and disorder of perception is hallucination. So I'm perceiving something which is not there, which does not exist. So and in that particular area, it's the auditory perception which kind of has the most kind of disorder basically. So that's why the person usually experiences auditory hallucinations most. Yeah.
Hello.
Yeah, Manisha.
Madam, please clarify the first one again. Audible thoughts.
Audible thoughts is where whatever you're thinking, you feel that it's being kind of said aloud on a mic. So the person is kind of afraid to speak out because the person feels that the person who is in front of this particular person knows what he is thinking. So the person is even afraid to think because the person feels that whatever he's thinking, it is being said aloud, and everybody around him is knowing what he's thinking.
Okay.
Okay. So
Okay.
that
Okay.
is
Thank
why
you.
there is mutism, like the person kind of stops speaking, and the person also kind of tries not to think because the person feels that people surrounding him are knowing what he's thinking because he can hear his thoughts aloud. Okay. Okay, so these three are disorders of perception, mainly auditory hallucinations. Next is disorder of thought, where thought withdrawal comes, where the person feels as if thoughts are being removed from their mind. Next is thought insertion, where again the person feels that thoughts are imposed by some external force. So the person might experience the thoughts that the thoughts that he is having are not his own. He might feel that it's somebody else who is imposing their thoughts over his mind. Thought diffusion or broadcasting. Now again, this is where the person feels that his thoughts are being like experienced by others who are surrounding him. So again, this is so you have to remember that auditory hallucinations and these thought disorders are very related. Once the person starts having auditory hallucinations, the person is going to have these ideas as well. The person will have ideas of thought withdrawal. The person will have ideas of thought insertion to an extent that the person starts believing that this is true, and then it turns into a delusion. Next is made feelings or affect. Now, this is in the other area. These are motor behavior disorders. Okay. So, made feelings or affect. What is made feelings? It's where whatever the person is feeling, the person feels it's not his own feeling, it's somebody else's feeling. So, if the person is crying, the person feels that he is not feeling like crying, but it's some alien body's emotions that he's feeling. He could even claim that it is some dead person, so it could be that as well. Made impulses, so the person does something and feels that he didn't want to do that, uh, or he's being forced to do that. So it's if you have come across OCD, in OCD, generally a person has a thought, an intrusive thought, and the person, like suppose the person can have a thought of contamination. The person feels that his hands are dirty. So the person has an urge to wash his hands. And uh, as long as the person doesn't wash his hands, the person doesn't feel relieved. The person keeps feeling anxious. So what can happen is the person is forced to wash his hands. So similarly, in made impulses also, the person would do certain acts and the person would claim that he didn't want to do that. He's being made to do that. And this is where we have to be very careful about, kind of distinguishing it between OCD and schizophrenia. Because in OCD, the person will always tell you that I know that this thought and this action is mine. I know this is my feeling. And in schizophrenia, the person would be very convinced that he is being made to do this by some alien body. And he is not doing this. He doesn't want to do this. Uh, yeah, delusions are thoughts, hallucinations are perceptions. We'll get to that, Prerna. Okay, next is made volition or acts. This is again, it is in connection with the first two. Somatic passivity, where there are bodily sensations like sensory sensations, which the person feels again are being imposed by some external force. Delusional perception. Now, this is like normal perception has a private and illogical meaning. This term is no longer actually used, delusional perception, but it is a very interesting concept. This is a concept which kind of differentiates schizophrenia from other disorders. And it was believed that somebody with delusional perception is schizophrenic. It was kind of taken as a gold standard symptom. This person is having a delusional perception, so this person is having schizophrenia. So what is delusional perception? Delusional perception is a person is leading his life in a normal pattern every day, and suddenly one day something from his daily life uh, kind of triggers a delusion. So there is a very famous example, and we generally follow a book called Fish. Although it's a very prehistoric book, but we still have to follow it. I mean, that's how we kind of form our basics. So if you are interested to read Fish, I will send it to you. There is no, I don't have any qualms about sending it. In Fish, delusional perception has this very famous example. Like a person used to use a spoon which had the symbol of a crown every day. So the spoon which the person used to use every day had a symbol of a crown on it. Okay, that was something which is normal. Now, suddenly one day the person claims that I am of royal descent because the spoon that I'm using has a symbol of crown on it. And then the person starts acting and believing in that particular pattern. So this is something known as delusional perception, because this was an object which was used by the person on a daily basis, and now one day all of a sudden the person is believing this, and the person wants everybody else to believe it, and if others are not believing it, he's getting angry, he's getting aggressive. And this is something, a belief which we can't just shake it off, and the person believes it firmly, the person is unable to shake it off. So this is again a very significant symptom of schizophrenia. If something like this happens, then we are kind of sure that the person is experiencing schizophrenia. Okay. Another example is a person might be sitting on a veranda every day and he watches cars pass by, but suddenly one day a car, the number plate behind the car reminds him that this is the particular time, this is the particular date that I'm going to be murdered. Or a person might see his friend every day, but suddenly one particular day, one fine day, the person feels that I know she wants to kill me because she's wearing red. So this is the kind of assumptions that somebody has. Okay, yeah, I would. So these are the first rank symptoms. Okay, we will be discussing all the symptoms in detail, but that is Snyder's first rank symptoms. And even today, we also kind of follow by the first rank symptoms. Whenever there is a client that we have, we first ask that, uh, do you hear do you hear voices? That's the first thing. Again, agar we feel that this person might have schizophrenia, so we kind of ask, do people speak to you, or do you have, can you hear voices which others cannot hear? So that is how we particularly ask. Yeah, Manisha. Manisha, would you like to ask a question?
Ma'am, this is by mistake.
Oh, okay, 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 okay. Right. Okay, so let's start again now formally. All right. So this is clinical features. First is thought and speech disorders. Why is thought and speech connected? Because our thought is reflected by our speech. So if I'm not having organized thought, I won't be able to speak like this. If I'm not having attention, I won't be able to speak in an orderly manner. I won't know the trail of my speech if my thought is not organized. And this is where schizophrenics have a problem. So, autistic thinking. Here, thinking is governed by private and illogical rules, like we talked about delusional perception. The patient may consider two things identical because they have identical predicates or properties. That is, Lord Hanuman was celibate. I am celibate too, so I am Lord Hanuman. You understand what is celibate? Celibate is brahmachari. So Lord Hanuman was brahmachari. I am also a brahmachari. That is, I haven't also married. So this means I am Lord Hanuman. Okay, this is a sudden conclusion that the person will draw all at once, one fine day. Loosening of associations is a pattern of spontaneous speech in which things said in juxtaposition lack a meaningful relationship. So, again, the trail of thought is fleeting. So, the person is talking about one particular concept and then the person is talking about another concept. Just a minute. Hello, Amito. Hello. Okay. Right. So, loosening of associations is a pattern of spontaneous speech in which things said in juxtaposition lack a meaningful relationship, or there is a idiosyncratic shifting from one frame of reference to another. So, example is the person. This is the normal speech that the person would be having. So, you may not be able to retrieve a lot of information from the person because the trail of thoughts will be missing. So it will be tangential. I like to dance, all people have hands. The next day, when I'd be going out, I took control. Like I put bleach on my hair in California. So, like, two different subjects are kind of spoken in juxtaposition to like they are of two different contexts, and this is how the thought will be. And what we call this tangential thought. So if you would ask the person ki, okay, so tell me, how did you get here, how did you get to the hospital, so the person would be like, oh, today I woke up and today I just saw one lark. There is a superstition with one lark and I was terrified. And then the person will just go off to another, one day, this particular family member of mine had seen a lark, and this happened to him. And so you have to kind of keep guiding the person ki, okay, but tell me, how did you get here? And the person may not even come to the main point of the question. Now you might be thinking ki, oh, even we do that sometimes, but no, you do come to the point, you do answer the final question. And when you do that, that is known as circumstantiality, that is known as the circumstantial trail of thought. Schizophrenics have tangential trail of thought, they are unable to attend to that particular question, so they will trail off and off and off and off. And so the speech is often described, this kind of speech is known as disjointed speech. And if loosening becomes very severe, speech becomes virtually incomprehensible. And this is known as incoherence. Incoherent speech is where we are unable to understand what the person is speaking. Okay, so if the speech is described as being disjointed and if the loosening becomes very severe, then speech becomes incomprehensible. So again, thought and speech is related. So when thoughts are like fluctuating a lot, we are unable to speak it, we are unable to kind of bring words to kind of convey it, and therefore our speech also gets disturbed. Thought blocking. Now this is, there is sudden interruption of stream of speech before the thought is completed. If you would remember, this was a thought disorder that we were we had seen in the first rank symptoms, and thought blocking is actually very common. Now, remember, there are many types of schizophrenia. There are two main types, which I guess you should keep in mind from now on. One is paranoid schizophrenia, and the other is disorganized or heavy phrenic schizophrenia. So these symptoms, why isn't this moving backward? Okay. Anyways, the previous symptoms like autistic thinking and incoherence, these are more common in disorganized schizophrenia. Thought blocking and all these are more common in paranoid schizophrenia. So, because paranoid, the person kind of has different kinds of delusions, might have persecutory delusions. Thought blocking is the person feels that this person has kind of implanted a machine in my house, which is kind of taking away all my thoughts because he wants to cause harm to me. So this is something which is more common in paranoid schizophrenia, where the person is speaking, then suddenly the person stops and the person is unable to recall what he was speaking about. And the person starts having persecutory delusions, ki, oh, somebody is removing the thoughts. And it's usually a neighbor or a family member whom the person hates. So after a pause, the subject cannot recall what he had meant to say. This may at times be associated with thought withdrawal. And again, thought insertion is also there. So somebody is putting these thoughts in my mind, somebody is withdrawing these thoughts from my mind. So it's kind of all related. Next is neologisms. Now, this is again more common in disorganized schizophrenia, where incoherent speech could be there. So neologisms are, as we know, see, basically neologisms are newly formed words or phrases whose derivation cannot be understood. So in schizophrenia, actually, we cannot understand the derivations, but we do form neologisms on a regular basis. So on Google, the Urban Dictionary is kind of full of neologisms, new words, which are, currently in trend. But in schizophrenia, this kind of takes a different turn. The person, we already have a word for it, but the person is unable to use that word. The person kind of forms his own word. So I got so angry, I picked up a dish and threw it at the 𝐒𝐿𝐴𝐻𝐿. So something which you cannot understand. Next, the person might call a hat a head shoe. Okay. So these are created to express a concept for which the person has no dictionary word. Another thing is known as word approximations. So sometimes, again, normal words are used in unconventional or distorted way, but the derivation can be understood. In this case, the derivation can be understood even if bizarre. So word approximations could be like the person might use beep beep for a car, or paraphasias like ballot for banana. Okay. Next, we come to delusions. So one of the major symptoms of one of the major clinical feature, these distortions in thought and speech. In thought, basically, it is delusions. And often I find everybody confusing between delusions and hallucinations. Please don't confuse between these two. Don't use these two terms interchangeably. These two concepts are totally different. Please don't use delusions and hallucinations, these two terms, interchangeably. Know what they mean, and you will understand why I told this. Okay. So, delusions is a disorder of the thought. It is in your mind, it is what you are thinking, something which is kind of untangible. Okay. It's in your mind, it's all in your mind. And hallucinations is perception. You may not be able to see it, but for the schizophrenic, it is real. The person can feel it. The person can either see it, the person can either hear it, the person can either feel it. So it is a perception which the person is experiencing. That is hallucination. Hallucination can be of 5 types. It could be auditory hallucinations, visual hallucinations, gustatory hallucinations, tactile hallucinations. Delusions, on the other hand, these are disorders of thought. Okay, these are not concerned with hallucinations. Yes, these two are related. Hallucinations can cause delusions to arise, but that doesn't mean we can use these two terms interchangeably. Often a person may have delusions without hallucinations. Okay. And another thing is, these two are known as psychotic symptoms, and they're not just present in schizophrenia. This is again something which you have to be very cautious about. Delusions and hallucinations could be present in severe depression, in mania as well. Okay, so these are psychotic features. It doesn't mean a person having these features need to have schizophrenia. For schizophrenia, we need the other symptoms as well. So we will be discussing about the ICD-10 criteria as well. So remember, what is delusion now? Delusions are false, unshakable beliefs which are not in keeping with the patient's socio-cultural and educational background. Now, this is again very important. Okay, now false, unshakable belief. So the person believes it. It is difficult for the person to unlearn, not, unlearn it. It is difficult for the person to not believe it, and it is unshakable. Unshakable is somebody else also is unable to convince this particular person ki, whatever you are thinking is wrong, whatever you're thinking may not be true. So it is difficult, it's unshakable. So others cannot shake off this particular belief which the person is having. So if a person believes that my neighbors are conspiring against me, the person's family members cannot convince the person that no, it is you who is thinking in a wrong manner. Rather, this person who is thinking that my neighbors are conspiring against me might even feel, oh, my parents might have joined my neighbors and now they're all conspiring against me. So now this is false. Okay, something which has to be false, because again, conspiracy can happen. So, anyways, which are not in keeping with the patient's socio-cultural and educational background. Now, socio-cultural, why? Because there are certain beliefs in our traditions which might be viewed as nonsensical in the Western traditions. Again, there might be some traditions in the Western worlds which might seem nonsensical to us as well. So, again, it is not in keeping with the patient's socio-cultural background. So, see, one patient once told me the person believes that people who are wearing red are worshippers of the sun, and people who are wearing blue are worshippers of the moon. This is what the person believes. And this particular person was a worshipper of the moon. And so, whoever this person would find is wearing red and similar colors would feel that they are worshippers of the sun and they want to cause her harm, which indirectly will be causing harm to the moon goddess. So now see, moon god, sun god, these are things which are not very something very, it doesn't really go with our culture. We are more of Hindu deities and other kind of religions. So this is something which is not keeping with the patient's socio-cultural background. At the same time, it is also not in keeping with the person's educational background, because this person was a postgraduate, mind you, and she was doing her PhD. Okay, so it doesn't go with the person's educational background as well. So this is again something which you have to keep in mind, because with people who are coming from a rural background, there is, I am a Bengali, so I have been trained in Calcutta University. There is a common term known as ban. So people say ban mere che. Ban is something like a bow. Okay, so it is a very common thing in rural areas. Somebody ban mere che amar kane. So somebody has kind of inserted something in my ears, and they usually go to some magico relief healers, and sometimes it actually works also. So this is again something which is in keeping with the person's cultural context, because a lot of person does believe that some things like this can happen. In now I'm practicing in Delhi. Here nazar is something very in keeping with the person's cultural background, and a lot of people have come up to me and told, ma'am, nazar laga hai, buri nazar laga tha, and that's why this happens with me. I do not go to huge extents to prove this person wrong. No, 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 there is nothing called nazar. I won't be doing that. Okay. Rather, I would let the person come to a shakable stance. Here, jo unshakable wala cheez hai na, उससे at least I would help the person to come to a shakeable area. Do you really think this is possible? Okay, even if I'm considering कि नजर के लिए this has happened, is there some percent of chance कि बिना नजर के भी ये हो सकता था? I mean, it could have happened even if आप पर नजर नहीं था किसी का. And if the person is on a ground कि हाँ हो सकता था, but I'm sure ये नजर है, तो then you kind of feel okay, this person is on a shakeable ground. But when the person is in an acute phase of schizophrenia, these beliefs are kind of very unshakable. Okay. Now, there are two types of delusions, primary and secondary. Now, primary delusion is what we were again talking about, those kind of this thing, perceptional delusion, where it was like primary delusions, they arise de novo. De novo is all of a sudden. It cannot be explained on the basis of other experiences or perceptions. And these are also known as autonomous delusions. जैसे कि that those examples where the person is suddenly feeling he's of royal descent because he has a spoon which has a crown on it, or the person suddenly feels that today he's going to get murdered because a particular car had a particular number plate, or suddenly he feels that his friend might cause him harm because she's wearing red. So they're arising de novo. They did not have any hallucinations before this. ऐसा नहीं कि कोई hallucination हुआ, the person kind of heard people talking about this particular person, ऐसा कोई hallucinations नहीं हुआ. Suddenly the person is having these kind of delusions, and there is enough evidence to prove that whatever things that he's thinking is wrong, it's false. So this is a primary delusion, and this is very characteristic of schizophrenia. This is again very characteristic of that type of schizophrenia which has a very poor prognosis. Next is secondary delusions. Secondary delusions can happen in schizophrenia as well. Secondary delusions can happen in severe depression. It can happen in mania as well. Usually in secondary delusions, hallucinations happen first. So the person might hear a sound and slowly it kind of turns into a voice. The voice could be either abusing this person, or the person could hear two voices abusing this particular person, or the person might hear live commentary, like whatever the person is doing, there is live commentary in a sarcastic manner, in a pessimistic tone, which kind of makes the person feel bad. So usually it's hallucinations which happen first, and the person might have feelings of thought insertion, thought withdrawal, thought blocking. Just as slowly, when the person is kind of hearing two voices, which is abusing this particular person, the person kind of feels it's his neighbors who are bickering about this particular person. And the person starts having a delusion, oh, they want to cause me harm. They want to cause me harm because they want to take away all my property. Now it is a delusion. There was a hallucination, there was auditory hallucination, which is giving rise to a delusion, which is also unshakable. We cannot make the person unbelieve what he's believing right now. But this is a secondary delusion. This is again common in severe depression as well, because in severe depression also, the person does have auditory hallucinations. So the only difference is in depression, it is mood congruent. That is, the person has delusions ki, you should die. You're not worth living. You do not deserve to live. Mood congruent. The person is also feeling that particular way. The person is also having these feelings of worthlessness. In schizophrenia, it's not that. It's not that. In hallucinations, it's like the person might have very grandiose thoughts. I am somebody who is of importance, who is of utmost importance, and how dare these persons talk against me. So it is not mood congruent. Mood congruent is not keeping up with the emotions. Next is delusions. Okay, so these are the types of delusions. Delusions of persecution, which is very common. Delusions of reference, that is being referred to by others. So if the person kind of passes through the road and finds a crowd which has kind of gathered and kind of gossiping among themselves, he feels that these people are talking about this particular person. Delusions of grandeur, like exaggerated self-importance. I am God, I am Netaji. It could be something like that. Delusions of control, that is, I'm being controlled by an external force. My neighbor is controlling me. Often delusions also has one another kind of characteristic. It could be desired. What is desire? Something which cannot be explained scientifically. So and often, and again, see, remember, person not keeping up with the person's educational background. So I even had a patient who was a scientist, and he told me that one of his neighbors had fitted a kind of satellite which was recording all his moves and all his actions, and it was some kind of an invisible satellite which he kind of explained through his geek understandings, but it was something which is not possible. So again, you have to consult with other scientists as well कि ऐसा कोई device आया है क्या. So then you are kind of convinced कि no, ऐसा कुछ है नहीं. So then again you have to, but yeah, the more intelligent the person is, the more convincing will be that particular person. So okay, and remember, in schizophrenia, intelligence is not affected, intelligence remains intact. Okay. So okay, next is somatic or hypochondriacal delusions. So these are delusions about the body. It could be like insects crawling over my skin. It could be insects crawling on my, having a feeling of insects crawling over my scalp. Um, and so the other clinical features of schizophrenic thought disorder could include over-inclusion, tending to include irrelevant items in speech, impaired abstraction, loss of ability to generalize. So the person will be unable to generalize. The person, like, that is why when the person is passing through the road, the person keeps on feeling that all these people are talking about me. The person is unable to generalize that no, they might be talking about something else as well. Concreteness. So because now their thinking is more concrete in nature, because their abstraction is kind of impaired. So they might be describing things based on their concrete features only. Perplexity and ambivalence, we kind of discussed these before also. Next is verbal behavior and speech disorders. So the person might show complete mutism with no speech production, poverty of speech, there is decreased speech production, poverty of ideation, where speech amount is adequate, but it conveys very little information. Echolalia, that is repetition or echoing by the patient of the words or phrases of the examiner. So whatever I am saying, the patient is also repeating. There is another phenomenon known as echopraxia, where the patient would imitate the acts which I'm doing. So if I'm itching my this thing like cheek, the patient would do that as well. Perseveration. Perseveration is persistent repetition of words beyond their limitations. The person keeps on repeating what could be an abuse, could be of one certain word beyond its relevance. So might keep on repeating it. Verbigeration. Now this is again senseless repetition of the same words. So these two are kind of similar. In perseveration, it could be ki you might ask the person ki what is your name, and the person might tell ki my name is John, and the person might keep on repeating John, 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 John. Suddenly, after a few moments, John. So this is perseveration, where the person had answered your question. So this was done to fulfill a certain goal, but it kept on repeating. And in verbigeration, the person is repeating one certain particular word over and over again without any particular context. Here comes disorder of perception. This is hallucination. Disorder of perception में सबसे common है auditory hallucination. And so basically, what is hallucination? Perceptions without stimuli. Okay. Only the person perceives it. Others won't be able to perceive it. And what is perception? Basically, perception is sensation with meaning. Perception is sensation along with meaning. So whenever we add meaning to our sensations, that is perception. So we hear a voice and we identify whose voice it is. We are perceiving it. Okay. And when we are unable to identify, we are actually just sensing it. The moment we are adding meaning to our sensations, it turns into perception. And it happens, all our sense organs basically, they kind of fire only when there is stimuli, right? But these perceptions happen without stimuli. Okay, so only this particular person is experiencing it and others are not experiencing it. Now there could be three types of auditory hallucinations as well, because this is actually again the stage by which a person who is having auditory hallucination passes. Because the person in, right in the beginning, the person does not hear human voices, like voices conversing or something like that. The person, it starts with hearing elementary auditory hallucinations. Could be hearing simple sounds. Okay, it could be a horn. So it might even start with, the person might hear a loud horn of a car, and the person might get very startled and ask his family members, "Hey, did you hear this particular loud sound?" And the family members would be like, "No." That is where the person starts having these feelings of perplexity and confusion as well. Ki, okay, so what is happening? Next could be thought echo. Thought echo is where the person is hearing his own thoughts. The person is hearing his own thoughts. Here, the person can identify that these thoughts which I am hearing, these are mine. These thoughts are mine. Next is third person hallucinations. Third person hallucination is where the person hears voices which are arguing. So the person identifies that these voices are not mine, these voices are somebody else's, could be my neighbors, who are speaking about me in third person and who are kind of abusing me. So in the third stage, the person is unable to kind of identify that these are arising from his own mind. So insight is lost in schizophrenia. Insight is lost, and that is why the delusion is known as a false unshakable belief. We can't shake this particular belief of the particular person. And voices commenting on one's action, this is also a third person hallucination. So third person hallucinations are believed to be characteristic of schizophrenia. Next, disorders of affect. Affect is our emotions. Okay. So it could include apathy, emotional blunting. Apathy is basically not feeling anything. So if the person is witnessing somebody crying, the person is not feeling uh, anything. The person is not feeling any sense of sympathy for this particular person. Emotional blunting, the person himself is unable to express his emotions. Emotional shallowness, so blunting and shallowness, these are both inability to express emotions. Blunting is on a more severe level. Anhedonia, inability to experience pleasure. Inappropriate emotional response, so emotional response is inappropriate to thought. And again, the person might have difficulty establishing emotional contact with other individuals, and also this would cause a disturbance to establish rapport with the physician as well. Next is disorders of motor behavior. So there could either be a decrease or there could be an increase in psychomotor activity. So decrease could be decreased spontaneity, inertia, stupor, and increase could be excitement, aggressiveness, restlessness. Mannerisms, grimacing, stereotypies, these are known as motor disorders. So mannerisms is again doing one particular thing over and over again. The person might do like this over and over again. Grimacing is also very similar to mannerisms. Stereotypies is repetitive strange behavior. Decreased self-care, poor grooming are common features. Catatonic features are commonly seen in the catatonic subtype of schizophrenia. Yes, mean.
Ma'am, yeah. What is motor behavior, ma'am? What is motor here?
Motor behavior is anything which we are doing with our limbs, basically, hands.
Okay,
Huh.
motion. Okay,
So, like, where the person is, not moving, like inertia and stupor is where the person is not moving any area of the body, neither moving his hands, neither moving his legs. Excitement, aggressiveness, where the person has overactivity. So, and these are also different types of motor behavior, like stereotypies that I'm talking about. Like could be strange behaviors which the person is kind of repeating, motor behavior, touching his hair constantly, adjusting his specs constantly, doing like this. So these are parts of motor behavior disturbances. And the significant motor disturbance is found in catatonic type of schizophrenia, which we will be discussing later. uh, is it clear, Yasmin?
Yes, ma'am. Yeah, it's clear.
Okay, okay. Next, we come with negative symptoms. So, negative symptoms include affective flattening or blunting, attentional impairment, evolution, apathy, anhedonia, asociality, which is known as social withdrawal, allogia, lack of speech output. So you would find that there are known as positive and negative symptoms. So negative symptoms is basically where the person kind of stops responding, uh, cannot express anything, cannot express anything, cannot talk, unable to relate with other people, socially withdraws. Uh, would you ask a question, Yasmin?
No, ma'am. It
Oh,
was the one I raised. So,
okay,
okay, there is an
okay.
option to lower hand. Okay, ma'am.
Okay, okay. So yeah. So in negative symptoms, again, negative symptoms are more common in disorganized schizophrenia. What are positive symptoms? Positive symptoms are actually hallucinations and delusions, and these are more common in paranoid schizophrenia. So there is poor verbal as well as non-verbal communication with poor facial expression, decreased eye contact with usually poor self-care and social interaction. Other features would be decreased functioning in work, social relations, and self-care, loss of ego boundaries. What is this? Like feeling of blurring of boundaries of self with the environment, uncertainty and perplexity regarding own identity and meaning of existence. I have an example which I will present you tomorrow in the case study, where loss of ego boundaries could be more easily explained. It is kind of a feeling where the person feels that he no longer has a physical existence. He has merged with the environment. He could be that leaf, he could be that sky. So it's where there is kind of a loss of the physical boundaries which the person has. Multiple somatic symptoms is seen in the early stages of illness. Insight is absent, social judgment is poor, and there is no clinically significant disturbance of consciousness. Orientation, what is orientation? Where we kind of inquire the person about what is today's date, month, year, where is he. So the person doesn't have any kind of confusion with regarding to orientation, time, place, person. Attention, there is no problem as such, but the person has difficulty in concentrating, does have attentional problems, but not that kind of an attentional problem which we're talking about where the person might need help. So the person, somebody who is having paranoid schizophrenia, is able to continue his studies, is able to continue his work. So in disorganized schizophrenia, attention is significantly affected because the person is, as you would know, attention, concentration, these are required for good speech as well. So the person is unable, as severe the person becomes, as severe the symptoms become, the person has difficulty to speak and all, and their attention is definitely impaired. However, memory intelligence remains intact. Yeah, so basically, there is usually variability in symptomatology over time in which the case can be marked, and there is no obvious underlying organic cause that can explain the causation of symptoms. There is no prominent mood disorder of depressive or manic type. If a person has three separate episodes, one episode of schizophrenia, one episode of major depression, one episode of mania, then it is not called schizophrenia. It is known as schizoaffective disorder. Okay. Otherwise, we have to kind of be sure that the person has ever had only an episode of schizophrenia and never episodes of depression and mania separately. Yeah, Pratibha.
Ma'am, can you please explain the sixth point, like the first point on the slide?
The variability in
Yes, sixth point.
symptomatology. Okay, the person might have different symptoms throughout his course of illness. So the person initially might have only positive symptoms, like might have only delusions and hallucinations, but over time the person might have just negative symptoms, like there could be flattening of affect, avolition, anhedonia, person is not speaking, uh, reduced sociability, or the person might, you know, stop having these symptoms at all. So a schizophrenia person who is having schizophrenia doesn't have the same set of symptoms throughout his life. The symptoms keep changing. The person presents with different symptoms, but yeah, related symptoms, which we know are associated with schizophrenia, because no other disorder has so many slides explaining the kind of symptoms a person might experience. As you could see, affecting the thought area, affecting the perception, affecting speech, affecting motor behavior. So a schizophrenic, when you see a person, will not be presenting with all symptoms all at once. It might change over time. This is what is it clear?
Yes, ma'am.
Okay, so yeah, we do follow the ICD-10 criteria. I am a follower of ICD. So these are the symptoms of schizophrenia. As you could see, there are two groups actually. So at least two of the symptoms, so either at least one of the symptoms, uh, syndromes, symptoms and signs listed under one, or at least two of the symptoms and signs listed under two is in the next slide, should be present for most of the time during an episode of psychotic illness lasting for at least a month, or at some time during most of the days. So for in ICD, the criteria is the symptoms must last for a month. Okay, and so here we go. Thought echo, thought insertion, thought withdrawal, thought broadcasting, delusions of control, hallucinatory voices, persistent delusions, and for two, persistent hallucinations in any modality, neologisms, catatonic behavior, negative symptoms. So either two from here must be present, or one from the previous symptoms should be present. ICD is the classification system which is laid down by WHO. Is it clear?
Yeah, yes, ma'am.
Yeah. Okay. Yeah. Pratibha, do you have another question, or that was it? Oh, yeah.
No, ma'am. Sorry.
Right. Okay. Yeah. So let us now kind of know the course of schizophrenia. So what is the course of schizophrenia? These are the stages. There could be a pre-morbid phase where the person might have mild motor, cognitive, and social impairments. Cognitive are those which are associated with the thought, speech. These are the cognitive symptoms. Motor, again, the person might be socially withdrawn. The person might have certain mannerisms, but not very significant. Next is prodromal. Prodrome phase is kind of the onset of schizophrenia. However, the prodrome phase looks very similar to depression, where the person kind of socially withdraws, doesn't feel like talking, locks himself in a room, might lock himself in a room, uh, might not might have poor self grooming, may not take proper care. But these symptoms are again very synonymous with symptoms of depression. So we kind of get very cautious whenever we see these symptoms, because we kind of assume that either it is a prodrome phase or it could be depression as well. ICD doesn't need notes. I'll be sending this PPT, Manisha. You will get this PPT. And ICD is a classification system. It is used worldwide. I hope you know about the World Health Organization. So it is laid down by the World Health Organization. It's an classificatory system, okay? And it is there for every modality of treatment, every modality of disease. It's not just there in psychiatry, it is there in other forms of I mean, medical fields as well. So there is an ICD manual for oncology, there is an ICD manual for gastroenterology, there is an ICD manual for different kind of endocrinology. So there is, so psychiatry ka jo hai, usme these are the criteria, and you just need to kind of know the criteria. And ICD-10 is downloadable from internet as well. And again, see, ICD-11 is going to arrive next year. So yeah, yeah, you will be getting this. I hope the slides would do. I have mentioned all the criteria of schizophrenia there. Okay, these are all the criteria of schizophrenia. Anyways, okay, so yeah, prodrome phase, as I was talking about, is a very important area. We must be very cautious about this particular area because the symptoms again are very similar. And a prodrome phase can again persist for a few months, or sometimes it could persist even for like a year, okay, until the active phase starts, the active phase of schizophrenia starts. In the active phase of schizophrenia, there are florid symptoms like very prominent hallucinations, delusions, or speech incoherence, and different types of negative symptoms. But in prodrome phase, it is usually kind of not full blown, kind of under the wraps, and might seem very similar to depression. And even after schizophrenia is treated, the person might enter the residual phase, which is again very similar to the prodromal phase, where again positive, negative, and cognitive symptoms may persist. One thing is you must keep in mind is age. So again, as I was talking about disorganized and paranoid schizophrenia, disorganized schizophrenia has more of the negative symptoms. And again, as I was talking, disorganized schizophrenia has a poor prognosis. But at the same time, disorganized schizophrenia also has an early onset. So generally, it could start from years of 12, age 12. However, so disorganized schizophrenia has an early onset, usually age 12, again has a poor prognosis and mainly has negative symptoms. Paranoid schizophrenia usually starts in the 40s. It usually starts in the late 40s or early 40s, and it mainly has positive symptoms, that is hallucinations and delusions, and it has a good prognosis. It responds to treatment, and the person might be symptom free forever in his life, except for that episode of schizophrenia. So this is something which we have to be very concerned about. And this prodrome phase is something which is again most associated with this organized schizophrenia, and which usually doesn't have a very good prognosis. Now let us talk about the clinical subtypes. Paranoid schizophrenia, as I was talking about. So paranoid schizophrenia is characterized by the following clinical features. And in addition to the general guidelines of schizophrenia, which were described earlier. So this is again the ICD criteria, okay? Delusions of persecution, reference, grandeur. Hallucinations usually have a persecutory or grandiose content. So remember I was talking about secondary and primary hallucinations. So the hallucinations are usually of a secondary nature, and the delusions would be of persecution, reference, grandeur, control, or infidelity, and they're well systematized. So it is not very bizarre. It won't be bizarre. So delusional perception, the concept yahan pe nahi aayega. Delusional perception doesn't happen in paranoid schizophrenia. It is very characteristic of disorganized schizophrenia. And delusion of persecution, the person will kind of have explanations for his beliefs. So the personality deterioration in the paranoid subtype is much less than seen in other types of schizophrenia. So as I told you, the person can go to work, the person can keep studying, the patient may be quite apprehensive and anxious and appear evasive and guarded on mental status examination because the person does not want to reveal everything. Because so initially it is again difficult to establish rapport with a patient having paranoid schizophrenia. So the first few sessions are engaged in building trust, where the patient can open up, where the patient can say, because the patient will be very guarded during the clinical interview, because the patient will again feel ki me, my therapist is not one of the conspirators. The patient might have a idea like that as well. So again, onset of paranoid schizophrenia is insidious. Now, what is insidious onset? It means that you do not literally know कि कब से ये start हुआ है. जैसे it is very definite. The onset of disorganized schizophrenia is sudden and it's very definite. You know, on this particular day, suddenly she started feeling that I wanted to kill her or I wanted to cause her harm. But in paranoid schizophrenia, it's not like that. It is very, the person is usually unsure ki from when particular day this kind of thing started. It occurs later in life, as I was talking about, late third and early fourth decade. So late 30s or early 40s, as compared to other types of schizophrenia. The course is progressive and complete recovery usually does not occur. There may be frequent remissions and relapses. At other times, the functional capability may be slightly impaired. So the person is able to continue with his daily life. The differential diagnosis is usually from delusional disorders and paranoid personality disorders. These are two, again, different categories. So delusional disorders, what is it? It is very similar to paranoid schizophrenia, but in paranoid schizophrenia, for somebody to get a diagnosis of paranoid schizophrenia, the symptoms must last in a florid state for at least a month. For delusional disorder, the period till which the symptoms were there has to be very short, usually 2 weeks. Okay? So if the psychotic symptoms were there in this particular person for just a week or maybe 2 weeks, then we cannot call this person paranoid schizophrenic. We call it a delusional disorder. And agar the symptoms remain for like a month and more than a month, it's paranoid schizophrenia. And paranoid personality disorder is a completely different thing. It comes under the criteria of personality disorders. Okay, so this person is not schizophrenic. Somebody with paranoid personality disorder has never been schizophrenic. Okay, next is the disorganized schizophrenia. This is the kind of schizophrenia that you would generally find on the roads, begging, roaming around. They might wear, shawls during a very hot weather. So this is that is disorganized schizophrenia. And if you have ever observed somebody like this, you could make out that you won't understand what the person is speaking. The person would be talking something, but you cannot make out what the person is talking about. And you could see poor grooming, lack of self-care. The person can eat from the dustbin. So that is basically disorganized schizophrenia. Onset is usually early. And in disorganized schizophrenia, the following features are there. This is marked thought disorder. There is incoherence. Hi, KG Thomas, can you just mute yourself? Yep, thank you. Okay, so in disorganized schizophrenia, there would be marked thought disorder, incoherence of speech, severe loosening of associations. Delusions and hallucinations are fragmentary and changeable. Emotional disturbance. So again, the inappropriate affect, blunted affect, senseless giggling, mannerisms, mirror gazing, like looking at that particular person at the mirror for a long period of time, disinhibited behavior, poor self-care and hygiene, markedly impaired social and occupational functioning, extreme social withdrawal, and other oddities of behavior are also observed. And again, it recommends ICD-10 recommends a period of 2 or 3 months of continuous observation for a confident diagnosis of disorganized schizophrenia to be made. Again, in this case, the onset is insidious, usually in the early second decade, and it could be 12 years as well. Okay, the course is progressive and downhill. The recovery from the episode is classically poor. Severe deterioration without any significant remissions usually occurs over time. So, heavy phrenic schizophrenia has one of the worst prognosis among the various types of schizophrenia. Catatonic schizophrenia, as I was talking about. So, catatonic schizophrenia kind of is characterized by marked disturbance of the motor behavior. And in addition to the general guidelines of schizophrenia, which were discussed earlier, so there are three forms of catatonia. It could be excited catatonia, it could be stuporous catatonia, and it could be catatonia alternating between excitement and stupor. And an excited catatonia, there is increase in psychomotor activity, that is ranging from restlessness, agitation, excitement, aggressiveness to at times violent behavior. There would be increase in speech production with increased spontaneity, pressure of speech, loosening of association, and frank incoherence. The excitement has no apparent relationship with the external environment. Them getting aggressive has no connection with the external environment. And they kind of are hearing auditory hallucinations, right? So it is a reaction to those auditory hallucinations, their aggressive behavior. So excitement is not goal directed. Okay. And if excitement can become very severe, it is accompanied by rigidity, hypothermia, and dehydration. It could culminate to death as well. However, right now, this is not very common because there is treatment for catatonia. The treatment for catatonia is usually electroconvulsive therapy. The other form of catatonia is stuporous catatonia, where there is extreme retardation of psychomotor function, and the characteristic catatonic signs are usually observed. So, in this particular state, in a stupor, the person will stop doing any kind of motor behavior. The person might maintain a certain position for a long period of time. So, like the person may lie down for 7 days at a stretch, not doing anything, not eating, not going to the, not bathing, not doing anything, just lying on bed, no movement of any particular body part. That is kind of stuporous catatonia. And again, in this particular area as well, ECT has been found to be effective most. And then there is catatonia alternating between excitement and stupor. Now, in excited catatonia, what are the kind of, there are different kinds of motor behaviors which you could find in excited and stuporous catatonia. So let us kind of know those terms. One is mutism. Mutism is complete absence of speech. This is in stuporous catatonia. Rigidity. There is rigid maintenance of a rigid posture against efforts to be moved. So the person might be sitting and it is difficult to make the person move from his sitting position. This is again stuporous catatonia. Sometimes, when I used to work in a government, since my training happened in a government hospital, so the person would be brought in that chair itself. Just the way how the person is sitting in the chair, the person would be brought to the hospital just like that. Because the person could not be moved. The person is rigid. The person is sitting there and it is difficult to move the person out of that particular posture. So again, in this case, this is again a part of stuporous catatonia, and ECT is the treatment here. Negativism, apparently motiveless resistance to all commands and attempts. So if I'm instructing the patient, you move your hand, please stand up, the patient won't be doing that. That is negativism. This is again stuporous, a part of stuporous catatonia. Posturing. Posturing is also a part of stuporous catatonia. It is voluntary assumption of an inappropriate and often desired posture for long periods of time. So, a very common example is invisible pillow. So, the person might be lying on the bed without a pillow, but the person might shift his head, raise his head above the bed, just like as if he was lying on a pillow. And that position is maintained for, weeks and days. Stupor, as I was talking about, like no movement at all. Echolalia, echopraxia is more common in excited catatonia. So echolalia is repetition or mimicking of phrases which I'm saying. Echopraxia is also repetition of the motor activities that I'm doing. Waxy flexibility. So this is again a part of stuporous catatonia. In waxy flexibility, this is like the condition in rigidity, but in this case the person is not rigid. Here, in whichever posture you move the limbs and hands, the person will allow you to do so. And even sometimes very uncomfortable postures can be maintained. So in waxy flexibility, where the person is sitting on a chair and the person, you could like take the hand up and the person will maintain that particular posture, and you can even put it in a very uncomfortable position like this and the person would maintain it. And ambitendency is due to ambivalence, that is conflicting impulses and tentative actions are made, but no goal-directed action occurs. So example, on asking to take out tongue is slightly protruded, but taken back again. Like in ambivalence, we were telling the person is unable to decide what to do. And as I was talking about again, like before, mannerisms, stereotypies, automatic obedience, verbigeration, these are also present. And catatonic onset of catatonic schizophrenia is acute, usually in the second or the third decade. The course is often episodic, happens for a particular episode, and recovery from the episode is usually complete. However, residual features are present after 2 or more episodes. Differential diagnosis is from causes of stupor and catatonia. Now, schizophrenia is not the only type of illness where there could be catatonia again. Okay, so depression could have catatonia as well, severe depression. Next, there is residual and latent schizophrenia. So residual schizophrenia is basically after the active phase of schizophrenia is over, the person enters to the residual phase of schizophrenia. A residual has symptoms which are like the prodrome phase of schizophrenia, more of negative symptoms. Again, this and latent schizophrenia is also very similar. And symptoms are similar to prodromal symptoms of schizophrenia. So what is the difference? The only difference is that residual schizophrenia is diagnosed after at least one episode has occurred. Okay, so when a particular episode has occurred, then the person has had a florid episode of schizophrenia, and after that, when the person is kind of exhibiting negative symptoms, we tell that this is residual schizophrenia. However, if the person never had a very active phase of schizophrenia, never really exhibited florid symptoms, so in that case, we call it latent schizophrenia. And another one is undifferentiated schizophrenia, where we are not sure whether it's paranoid or disorganized, latent or residual. That is known as undifferentiated schizophrenia. So this is again a kind of a map where we kind of try to understand how the phases kind of progress, like the premorbid, prodromal, progressive, and residual phases. There is another common phenomenon known as post-schizophrenic depression. So some schizophrenic patients, they develop depressive features within 12 months of an acute episode of schizophrenia. The depressive features develop in the presence of residual or active features of schizophrenia and are associated with an increased risk of suicide. Often, schizophrenic patients can commit suicide, that is, after they gain insight. The active phase lacks insight, but after they are treated and they slowly, gradually gain their insight back, they feel very embarrassed about what has happened, about what has been portrayed to the world about them. And they tend to become depressed, and they also sometimes commit suicide as well. Another common distinction that we get in schizophrenia is a type 1 and type 2 schizophrenia. This distinction is no longer made, but somehow it helps us in kind of, it helps in the treatment, basically, this kind of distinction. This was done by T.J. Crow. This distinction was done by T.J. Crow, and type 1 syndrome has positive symptoms. It's mainly characterized by positive symptoms, that is hallucinations and delusions. And type 2 schizophrenia is predominantly characterized by presence of negative symptoms. This is also a list which is very helpful. So as you could see, in positive symptoms, it's delusions and hallucinations. In negative symptoms, there is flat affect, affective flattening, alogia, anhedonia, avolition, attentional impairment. So all starting with A, and these are negative symptoms because what happens is there is a decrease of that particular function. So affect flattens, speech, there is poverty of speech, the person does not withdraws from social interactions, apathy, that is the person kind of cannot emote expressions and emotions to others, attentional impairment. Okay, next is disorganized symptoms, is where there is inappropriate affect, a disorganized behavior, thought disorder, and loosening of associations. And if we kind of see the prognostic factors in schizophrenia, that is good prognosis and poor prognosis. Good prognosis is where the person is likely to get well and adapt back to his normal lifestyle. And poor prognosis is where the prognosis is kind of downhill. The person the person doesn't really get well. Okay, so good prognosis is where the person so there is an acute onset. It's an episode, it's an acute one, and it usually gets treated. Okay, is my screen visible?
Yes, now it's
Yes,
visible.
ma'am.
Okay. Presence of depression, predominance of positive symptoms, that is, it's more of hallucinations and delusions. Family history of mood disorder. First episode, if this is the first episode of the person, fat physique. This was a concept which was like way back. Okay, females have a good prognosis, good social support, presence of confusion, perplexity, or disorientation in the acute phase, because where the person is also confused what is happening with them. Proper treatment, good treatment concordance, and good response to treatment, outpatient treatment, and normal cranial CT scan. There are no changes, cranial changes in the brain. For poor prognostic factors, it's usually insidious onset below 20 years of age, which is like early onset, absence of stressor, poor premorbid adjustment. So the person was not well adjusted right from childhood, and there is no particular stressor which has caused this psychotic episode. Disorganized, simple, undifferentiated, or chronic catatonic types. Chronic course, that is more than 2 years. The person is having a chronic course of schizophrenia, on and off, on and off. Repeated episodes, recurrent psychotic episodes. Absence of depression, predominance of negative symptoms. So these are the negative symptoms, like all starting with A. Family history of schizophrenia, past history of schizophrenia, male sex, poor social support or unmarried, flat or blunted affect, absence of proper treatment, institutionalization, evidence of ventricular enlargement on cranial CT. If we talk about the prognosis, it has been seen that there has been a study which was done by ICMR um, in India, and it has been seen like, you know, that 27% had very favorable outcome, 40% had favorable outcome, 31% had intermediate outcome, and 2% had unfavorable outcome. This was a study which was like conducted over patients with schizophrenia who were treated in Vellore, and how well did they fare in when they got back to their normal lives. There is a certain percentage of schizophrenic patients who, in spite of treatment, do not recover. It is known as treatment resistant schizophrenia, and this generally has a poor prognosis. But however, it has been seen that in developing nations, the prognosis of schizophrenia is better. Like in countries like Nigeria, India, the prognosis of schizophrenia is better as compared to developed countries. And the reason has been thought to be that there is more social support in developing nations. Like in a country like India, a person does have social support. A person still lives in family, which is not a very common concept in the Western countries, where people start living separately from their parents right after they start earning, or even from high school itself. So social support is a very important factor for most psychiatric illnesses, and for schizophrenia also it is a very important factor. So you might often find a relative who had schizophrenia and who lives with their family. So as long as the person has a family, the person is well adjusted. The person does not require a lot of institutionalizations. Okay, so if we talk about the causes for genetic factors, yes, genes have been found to be highly it has been found that if a person has schizophrenia, his offsprings do have a high chance of having schizophrenia as well. And how are genetic studies done? Genetic studies are done by comparing monozygotic and dizygotic twins. As you know, monozygotic twins have gene sharing, 100% gene sharing basically, and dizygotic twins do not have that. And so the concordance rate for monozygotic twins is more as compared to dizygotic twins. So for monozygotic twins, every pair, like every person, every one member of a certain pair had schizophrenia. The other person in that particular pair, almost 46%, they had schizophrenia. So it's like about half of the pairs had schizophrenia. And often it has been also found, suppose like it's a monozygotic pair, one person is having schizophrenia, the other is not. But it has been found this particular person who does not have schizophrenia, this person's offspring can have schizophrenia. Okay, and the family, this thing is also very high. If both parents have schizophrenia, chances of child developing schizophrenia increases to about 40%. Okay. For biochemical theories, yeah, it has been found that schizophrenia, usually during periods of excitement, during hallucinations, delusions, there has been found to be an increase of dopamine. Other neurotransmitters have also been found to be disturbed, could be serotonin, GABA, and acetylcholine. But like for all other psychiatric illnesses, it is not sure which particular neurotransmitter causes the problem. So we cannot really just pinpoint one particular neurotransmitter, okay, this one elevates and so this is happening. No, we cannot do that. And that is why for every psychiatric disorder, we have to write so many different causes. We have to write about genetic factors, we have to write about the biochemical factors, we also have to write about the psychological and the environmental factors. And in schizophrenia, environmental factors do play a role. Stress, increased number of stressful life events before the onset or relapse probably has a triggering effect on the onset of schizophrenia in a genetically vulnerable person. Now, this is known as the stress vulnerability hypothesis. So what is it? So if a person is genetically predisposed to schizophrenia, then it is more likely that on the onset of stress, during a stressful life event, the person might have an episode of schizophrenia. So there are two people, okay? One is having a genetic predisposition of schizophrenia, the other does not have a genetic predisposition of schizophrenia. Both are undergoing the same level of stress. So both have failed in one particular exam. So now this particular person who has a predisposition of schizophrenia has more chances of developing schizophrenia than this other person who does not have a genetic predisposition. Okay, but that doesn't mean that this person can never develop schizophrenia. Okay, and this is one theory which is very important in the context of schizophrenia, known as expressed emotions. Okay, so there was a study which was actually conducted. Now, what are expressed emotions? Expressed emotions are measured in terms of hostility, critical comments, emotional over involvement. So hostility, you are very sure of it, where the parent is very abusive towards the child, physically, verbally. Critical comments, that is commenting on the person's activity every time. Emotional over involvement. Emotional over involvement is a mixture of possessiveness, overprotectiveness, and at the same time rejecting. So the parent might be very protective of the child, preventing the child from mingling with his peers, but at the same time the parent expects the child to be a very sociable kind of a person. So the parent criticizes the child for not being a good talker, but at the same time the parent prevents the child from mingling with his peers. So the ambivalence, this is again a form of ambivalence, and the child is kind of experiencing this from a very young age, and this does not have a very good prognosis. So in a study conducted by Vaughan and Leff in 1976, patients with schizophrenia were studied over a period of 9 months. And in this study, patients who were without any antipsychotic medication were exposed to more than 35 hours per week with a significant other with expressed emotions, were particularly likely to relapse, that is 92%, and the comparable rate in patients who received antipsychotic medication and faced less expressed emotions was 12%. So in the research conducted in the last 30 years, these findings have been replicated all over the globe, though the period of 35 hours per week has not been found to be significant. So now, basically what the study means is, in this particular study, the researchers, they made the schizophrenic patients spend at least 35 hours per week with a significant other who had expressed emotions, who had these particular 3 types of expressed emotions. And it was found that almost 92% of these patients had a relapse, as compared to those relatives, those significant others, who did not have expressed emotions, who had typically less severe expressed emotions. And this finding was kind of replicated all over the globe. So in India too, it has been found that in schizophrenics, their family usually involves in a lot of expressed emotions, a lot of hostility, a lot of critical comments. And this is a common experience that we all clinicians face while dealing with a schizophrenic, is that the schizophrenic client is easier to handle as compared to the schizophrenic's family. The family members are difficult to handle than the client himself. There have been family theories as well, but these are not much into validation right at this particular moment. There is an information processing hypothesis. This is something which still research is going upon, where the disturbances in attention, inability to maintain a set, and inability to assimilate and integrate percepts are common. Like the person is unable to attend to one particular information. That is why we find shifts in speech. And patients with schizophrenia may be first overly attentive to stimulus, but later may reduce or exclude attention to stimuli. There is possibly a breakdown in the internal representation of mental events. And for treatment, there are mainly three types of treatment. One is pharmacological treatment, that is treatment by antipsychotics. Next is treatment through electroconvulsive therapy. And later on, there could be therapy. Generally, it is cognitive behavior therapy has been found to be effective for patients with paranoid schizophrenia only. For disorganized schizophrenia, we usually counsel the family members on how to help the patient. There are usually rehabilitation programs which are run where the patients might be kept busy. Basically, for disorganized schizophrenia, the patients kind of are generally institutionalized, and in an institution you will find that these patients are engaged in different types of activities. Could be painting, could be singing, going to picnics, doing some basic work like making some handicrafts and all. um, and for the family members, for those schizophrenics who live with their family members, we help the family members on how to handle the patients when they get violent. But otherwise, as such, traditional psychotherapy is only effective for patients with paranoid schizophrenia and like ones who are undergoing residual form of schizophrenia, and but not disorganized schizophrenia, and not even prodrome schizophrenia, because in prodrome the person is um, not motivated to take therapy, because at that particular moment the person is kind of very paranoid. Okay, I if anyone has questions, you can ask me. Any questions? Yeah.
Hello, ma'am. Can I speak?
Yeah, sure.
Ma'am, my first doubt is you have told that the monozygotic twins, when they have schizophrenia, there's 50% chance of having. Will they show the same symptoms or the symptoms will be different?
No, as I mentioned, for every patient, the clinical picture changes over time.
Okay.
So it could start with delusions, hallucinations, only positive symptoms in the first episode. Then again, when the person is having a second episode, we could find just motor symptoms associated with some positive symptoms. And eventually, we might find in the next episode, it's just negative symptoms. So this is again something which is typically a poor prognosis thing. But
Okay.
again, for every patient, the clinical picture is different.
No, especially for this monozygotic twins, will it be similar?
Usually it has been found to be similar. This is actually very interesting, because in adoptive studies also, for monozygotic twins who were kind of adopted and raised differently, they had similar symptoms of schizophrenia, although they were living in different parts of the country.
One more doubt.
It's not the same for all monozygotic twins.
One more doubt. This
Yeah.
ICD-10 and DSM-5. Will they be listing out the same sort of criteria for classification of schizophrenia?
Yeah.
Or there is a difference?
No, they are kind of same, because right now DSM-5 also has 1 month of symptoms, and even like ICD-11, which has been under development for the last 5 years. Actually, it will be finally released in like 2022. So the body for the classificatory systems are same now. Like ICD, the ones who have collaborated for DSM-5 are collaborating for ICD-11 as well. So they both will be kind of zeroing down on similar diagnostic criteria. At least in terms of duration, they will do that.
Okay, ma'am. One more doubt.
Yeah.
When you talk about disorders of perception, we are talking only about auditory issues. Will they not have any visual issues?
Yeah. Most common is auditory hallucinations. Second most common is visual hallucinations, and tactile, gustatory, olfactory. These hallucinations are less common.
So that means in all senses they will have issues.
They will have, but the other three, like for tactile, taste, which is gustatory, and olfactory, which is smell, these three are less. Most common is auditory, second most common is visual. But actually, what happens, like again, visual hallucinations and hallucinations with the other sense organs, these are more common with people having organic deficits in the brain or temporal lobe epilepsy.
Okay. All
That
right.
is why we have to be very cautious whenever a person is reporting visual hallucinations. We first have to get a checkup, a biological checkup of this particular person. Ki this person never had epilepsy, so that is something which we have to be
Okay.
very concerned about.
That's all. Thank you.
Okay, okay. Yasmin.
Yes, ma'am. Ma'am, for the symptoms of the schizophrenia, so when it starts, there is no any hereditary, no, from the childhood they brought up well, but there is a sudden loss or intense grief. Did does cause the schizophrenia, ma'am?
Yeah, it can. As I was talking about, where there has been a stressful event in this particular person's life, which could be held responsible for that particular episode. It could be possible that the person could have a psychotic breakdown after a stressful event. And as I was discussing, the prognosis for such an event is good.
Okay.
And if there is no particular cause as such, and the person is having an episode of schizophrenia, the prognosis is poor.
Okay, ma'am. And in the treatment of schizophrenia, so
Mhm.
in this therapy and rehabilitation services, so does it, or we can have the meditation and other things also? Is there a positive result in lessening their symptoms?
Symptoms, as I was talking about, for paranoid schizophrenia, we
Mhm.
can work out with the patient, where the patient kind of realizes that they have schizophrenia and whatever they're experiencing is not true. In those areas, we can help the patient identify and manage their symptoms. But for disorganized schizophrenia, it gets a bit difficult.
Okay.
Tomorrow, I'll be showing two videos of some very good videos where the people are very well aware of the disease, of the disorder. Sorry, it's not a disease, it's a disorder. And they have come into terms with it, and they're also managing it quite well. So these people are suitable for therapy.
Okay, ma'am. And
Hmm.
like, apart from schizophrenia, if the person is having only a delusion,
Okay.
like always thinking that others will put me down, they will they want me to go bad, things like others will do something to them
Hmm.
bad or harmful, so that kind of delusion, so without this other symptoms of schizophrenia, so where can we categorize these kind of people, ma'am? Like
This is, see, you have to be sure about the duration. So if this is something which is persistent and other areas of functioning of this particular person is fine,
okay,
it is a personality disorder.
okay, ma'am.
It
Okay.
could be paranoid personality disorder, or it could be cluster B as well. So there are three clusters: cluster A, B, and C. So in
Mhm.
cluster A, we have paranoid, schizoid, and schizotypal personality disorder. In cluster B, we have borderline, histrionic, antisocial, and narcissistic personality disorders. So these kind of persecutory ideations. So these are not delusions. Okay,
Okay.
these are ideations. We have to differentiate between delusions and ideations. Delusion is unshakable. No matter what you do, the person will believe that is true. But ideation is where it has a shakable quality.
Okay.
So the person may think, ki, okay, what I'm thinking is too severe. But then the person kind of resorts to that thinking only. So that is more of a personality disorder.
Okay.
And in cluster B disorders, cluster B personality disorders also, persecutory ideations are very common.
Okay, ma'am.
Okay. And for ECT, Niyati. ECT is electroconvulsive therapy, where there are electrodes which are placed on on bipolar ends of the temporal lobe, and the person is like, an artificial seizure is elicited by like giving, basically passing, passing electricity through
Shock
the
treatment.
electrodes. Yeah, it's a type of treatment basically. It is not as dramatic as it is shown in films. It is a very standard form of treatment, and sometimes it is the only way by which the life of a patient can be saved, because in stupor and other forms of schizophrenia, in catatonia also, the patient doesn't eat, patient doesn't talk, patient doesn't you know do his bowels. So in these particular areas, a seizure is induced artificially through electroconvulsion, so that kind of the person regains back his activity. Okay. And for reference, I would tell you, there is a book by Neeraj Ahuja, which I feel could help you. And for getting the psychological aspect, so there are two books. One is a book of psychiatry that you could refer to, and the other would be a book of psychology that you could refer to. I prefer Carson and Butcher. That's one of my favorite books for the psychological perspective on clinical psychology. And for psychiatry, I prefer Neeraj Ahuja's book, but there is Kaplan and Sadok as well.
Thank you for attending this session. Don't forget to like, share and subscribe so that you get regular update on more valuable sessions, and visit www.counselindia.com for free ebooks and psychology related learning.